quick review of the anatomy of the tympanic membrane. So we talked about that pars flaccida where it may be retracted, which could be a cholesteatoma, right? We talked about that yesterday, just identifying the short process of the malleus, because that's where the ossicular chain connects to the tympanic membrane, and then that cone of light, so that light reflex, just some highlights there. Again, just review of the inner anatomy, so we can see the cochlea filled with that perilymph, and then we have the semicircular canal located above. You can see where that temporal bone is, and then that vestibular nerve, that vestibular cochlear nerve. So let's get into some definitions. So vertigo is typically experienced as distinct spinning or imbalance, falling forward. So that's different than dizziness. Dizziness can elicit to vertigo because the patient feels so dizzy they start to develop vertigo. So just understand that those are two different things. And then these are just some of the causes of dizziness and vertigo. Vestibular suppressants, so we'll be discussing these medications to treat the patient symptomatically. And essentially what they do is reduce the sensation of dizziness or vertigo for the patient. Meclizine and diazepam are usually our two go-tos. We can use Zofran as well to help symptomatically. That's a different class of medication. It's an antihistamine, but it acts as a 5-HT3 antagonist. So just FYI, we can use that, but these are the two primary that we'll discuss. Nystagmus is a rapid involuntary movement of the eyes, and then we'll go over how to assess for nystagmus. And then saccades is the ability for the eye to move on two fixed points in two different directions. And then if that's abnormal, they won't be able to move their eyes on those two fixed points rapidly. So perilymph is a clear saline fluid that surrounds the membranous labyrinth, and then the endolymph is the fluid inside of the cochlea. Think about it as this is the perfect temperature for your shower water. So it has a perfect balance because it's thermally balanced for us, because remember it's our vestibular system, it keeps us balanced. And it also is potassium filled. So that has to do with allowing it to work with the nerve to send signals from the inner ear to the brain so we can hear. Or we can balance, or we remain balanced. And then this is just a good depiction of the semicircular canals, otolith organ. You can kind of just identify some anatomy, but again, I'm not going to test you on anatomy, it just kind of helps you understand the different conditions. All right, so now vertigo, it's central versus peripheral. Those are our primary that we're going to discuss. It also is mixed vertigo, but that's really, it can be ambiguous, and you really need some definitive testing to identify that. So we'll go over some causes, and if we thought for any reason that it might be mixed vertigo, we would refer out to neurology or ENT so they can do specific testing, and we'll go over that as well. Duration, so some things that are going to help us determine whether it's central or if it's peripheral vertigo is duration, associated symptoms, triggers. So going into our HPI, medication history, the patient's past medical history, the patient's medication history, and then their social history. Do they drink alcohol, tobacco use, caffeine, etc.? All right, so specifically for peripheral vertigo, it's dysfunction of the labyrinth and or the vestibular cochlear nerve. So vestibular, that's the portion of the nerve that is responsible for our balance. Cochlear is the portion of that nerve that's responsible for hearing. So we will see hearing loss in some of these patients. Causes, so when you think about causes for peripheral vertigo, think about these as our differential diagnosis or our primary diagnosis. So what is causing the peripheral vertigo? It can be Meniere's disease, we'll talk about that, BPPV, labyrinthitis. So this is a correction on your slide. Vestibular neuronritis and vestibular neuritis. So they recently, current did an update. So vestibular neuronritis and neuritis are the same thing. Labyrinthitis is something different. And then alcohol intoxication, you know, if someone is too intoxicated, they can lose their balance. And then inner-ear barotrauma as well can also cause this peripheral vertigo. These are the symptoms of a patient that may present to you with vertigo. So they'll have, it might be more severe, sudden onset, plus or minus, nausea, vomiting, bless you, tinnitus, hearing loss. I say plus or minus because you can't guarantee that the patient is always going to have those symptoms. So it'll be important for us to identify what symptoms are associated with specific conditions, and we'll go over that. So for our physical exam, so a patient presents to us with vertigo. At this point, we don't know if it's a central cause or if it's a peripheral cause. The patient just says, I feel as if I'm falling forward, it feels like I'm on a ship rocking, those kind of explanations. So our HENT exam, we're gonna go through our ENT exam. We're gonna do our full otoscopic exam. We're also gonna do our cranial nerve exam, so our Weber and Renee. So they may have that hearing loss. The Romberg test, so that, we'll go over the test in lab. I won't stop the class, so that's what lab is for next week. So we'll go over the Romberg test where we ask the patient to stand with their arms out, close their eyes, and we usually wait about 30 seconds. If they start to lose their balance, that could be a positive Romberg test. The Fukuda test is when we ask the patient to stand and march in place. And as they're marching in place, they'll start to kind of rotate because they're losing their orientation. Now, these two tests are not specific to central vertigo or peripheral vertigo. It just tells us that it's some type of dysfunction in the vestibular system, right? Or proprioception, so they don't understand where they are in space. So, but they're not specific, but they kind of give us an indicator that this patient, along with them telling you they feel, spinning or dizziness, they are having vertigo. Now the Dix-Hallpike maneuver, we'll go over this in lab as well, that is specific for the diagnosis of BPPV. We'll do it in lab. So that's where essentially you have your patient on the table, you ask them to look at a fixated point. You have to make sure that it's going to be enough space on the table for you to kind of rotate their neck back. And as they're looking at that fixated point, you're looking for their eyes to move, to have that involuntary movement that the staff is. That would be a positive Dix-Hallpike, and that's associated with BPPV specifically. Any questions on that? Yep. Oh, we'll go over it, but non-paroxysmal positional vertigo. Yeah. Now, this is an overview slide of referrals for a patient with vertigo. It seems like it's a lot of information, but I want you to just kind of key in on what's going to determine our decision here. And really, it's the bilateral hearing loss or the unilateral hearing loss. Because they can have vertigo, they can have tinnitus. But if they have that bilateral hearing loss along with vertigo or tinnitus, we have to refer them to get an audiogram, and then we have to get, and then they can do audiogram or tympanometry within audiology. So we refer them to audiology. But if they have the unilateral hearing loss, that's when we're like, okay, we need to get some imaging that's specific to one's ear. Let's do the MRI and refer them to audiology, right? And so in the vignette, you will know if the patient has an audiogram, a recent audiogram. If they don't have an audiogram in the vignette, don't assume that they have one. That's your indicator to refer them to audiology to get an audiogram and to do tympanometry. And then we kind of went over this already as well, the basilar skull fracture. So if they have signs of a basilar skull fracture, we want to refer them out to neurosurgery. We don't want to wait for the audiogram, right? And usually if these patients have that skull fracture, they're going to present in a way where you know it's time to refer them out. I'm not going to wait, 2 or 3 days for audiology. We can refer patients to ENT as well. They have the VNGs, ENGs, and that caloric testing, which we'll go over. Neurology also has this ability to do the VNG and ENG caloric testing. So first, caloric testing, we're still in referrals for peripheral vertigo. So our patient is presenting to us with this sensation of spinning. They might describe it as dizziness, but they are falling imbalanced on the ship, that kind of thing. So for caloric stimulation, that's where we're doing the vestibulo-ocular reflex used to test for vestibular disorders. Essentially what happens is the audiologist or the ENT doc or the neurologist, they will insert water in the patient's ear, and the cochlea responds to that water, not the head. The head doesn't turn, the eyes respond to that stimulus, that cold water stimulus. The cochlea, remember, has fluid inside of it, so that warm shower just turned cold. And then the eyes are gonna start to compensate and look at that stimulus as to why you just turned my shower cold. So just kind of, the head will remain forward, but the eyes will start to turn. And it won't be, so initially they'll try to compensate, and then they'll start to slowly turn towards that stimulus. I'll show you guys videos as well, because I know it's kind of hard in a group of 78 with me with glasses on to see that. But I'll show you videos in lab so that way you can kind of get an idea of what normal and what abnormal looks like. Now, that's with cold water testing, and that's the normal response, right? We want, if we put that cold water within that ear, insert that cold water in the ear, the eyes should move towards that stimulus, not the head. So that's a normal caloric response. And then if it's warm water, it'll move away from the stimulus. And the idea is the cochlea is becoming dense and is moving down, so the brain thinks that we should be moving towards the stimulus, but we're actually not moving. It's only the eye, the ocular reflex is what we're trying to test to make sure that that's intact. That's why that's a normal response. And then the opposite would occur if it was abnormal. This is something that neurology does or ENT does, right? So what we need to know is, where do we refer these patients so they can do testing to definitively determine if it's central or peripheral vertigo, right? So continuing on for referrals for peripheral vertigo, they can do the electronystagmography. So that's where they use electrodes to actually track the movement of the eyes. Caloric testing, they can do it, but this is a step up. And then they also do the video nystagmography, where they use the cameras and they can look at the eyes. Those are two different pictures of neurology and ENT performing those tests. So those are more specific for them to be able to determine, is it central vertigo, is it peripheral vertigo? Because remember, our Fukuda test or our Romberg test, those are physical exam tests we can do in clinic, but they're not that specific. So this is where the experts come in and they can do this testing for us. All right, now going into central vertigo. Any questions on peripheral vertigo before we move on? Because I know that's kind of a lot of information. So central vertigo is the dysfunction in the CNS system. So think about this cerebellum, the brainstem. So we're here central. If it's peripheral vertigo, it's peripheral to the brain. So it'll be here in the ears, the cochlea. So that's kind of how you can remember that. Because the dysfunction for peripheral vertigo is going to be somewhere in the labyrinth or the cochlea, somewhere there. Whereas if they have central vertigo, the dysfunction is going to be in the brain, the cerebellum, or the brainstem centrally. These are some causes of central vertigo. Again, just think about these as your differential diagnosis as to why this patient is presenting to you with central vertigo. Can we determine if a patient has central vertigo versus peripheral vertigo based on them just coming into the class? Oh, sorry, into the clinic. We cannot, right? All right, so symptoms of central vertigo. Usually it's going to be less aggressive, it's going to be gradual, unlike peripheral vertigo where it is sudden and kind of intense, right? So they may have some neurological defects, so that's another key indicator for you. So muscle weakness, or they might have where nerves are not being innervated, decreased reflexes, those kind of things. Those are neurological symptoms. Again, for patients with central vertigo, we would still do our full HEENT exam. In clinic, we would do the Romberg test, the Fukuda test, but our key indicators in clinic for us is if the patient doesn't have fatigable nystagmus. So say, for example, a patient presents to you in clinic and you perform the Dix-Hall pipe, because at this point, you're not sure what type of vertigo this patient has. And you perform the Dix-Hall pipe, you see nystagmus, but it never stops, it continues. So for peripheral vertigo, it's usually fatigable, whereas with central vertigo, that nystagmus will stay no matter how long you look into that patient's eyes. It's still gonna be those involuntary movements. So that's what I mean by non-fatigable vertical nystagmus. Vertical, of course, going up and down as well. And then you can kind of think about, okay, brainstem, central, vertical, going up and down, that nystagmus is going to be up and down. And those are some abnormal neurological defects, that abnormal gait, facial drooping, unilateral weakness, decreased reflexes, etc. If we suspect that a patient has central vertigo, we're going to refer them to neurology, and they do have, like I said, that capability for the VNG, ENG, and caloric testing. All right, so going into some causes of mixed, which is central and peripheral vertigo. This is not an exhaustive list because it can get very complex when we refer them to neurology. But it's going to be two specific diagnoses that we talk about. So that's the vestibular schwannoma, also known as an acoustic neuroma, and then traumatic vertigo. So those are the two that we're going to highlight. All right, what are some symptoms and physical exam findings that increase your suspicion for central vertigo? Vertical nystagmus, what else? Yep, so this is non-fatigable, yep. Anything else? Anything on the physical exam aside from nystagmus? Facial drooping, yep. And then what are signs of a vascular skull fracture? Yep, the battle signs, so they'll have that ecchymosis on the mastoid, what else? Remember halo sign, where if they have discharge from the nasal canal or the ear canal, we can get a sample, dab it on a cloth, and then they might have that halo sign where it dries up and it's that straw-colored halo sign on the cloth. So that could be an indicator that it's a cerebral spinal fluid within the EAC or in the nasal canal. And then also the raccoonized. So that's the breakage of the blood vessels underneath the eye. So those are the top three. All right, so now, just so I keep you guys on this train, now we're going back into the differential for peripheral vertigo. We went over how is a peripheral vertigo patient going to present, how is a central vertigo patient going to present. We know that it could be some mixed causes, but now let's get into our differential of peripheral vertigo. So Meniere's disease, that benign paroxysmal positioning vertigo, I say keep BPPV because that's super long. Vestibular neuromyelitis or vestibular neuritis. So if you don't, just make that correction on your slides. Labyrinthitis, intoxication, alcohol intoxication, and then inner ear barotrauma. All right. For BPPV, so this is vertigo secondary to an otoconus located in the semicircular canals. So these otoconus are calcium crystals. Their normal function is to keep us balanced, right? So they also play a part of our vestibular system in keeping us balanced. They can dislodge into a place that they're not supposed to be, and if they dislodge into a place they're not supposed to be, it's going to cause us to become imbalanced. This is the most common cause of vertigo. Causes positional change, so a patient might present to you and say, I started to feel dizzy when I got out of my bed, or I started to feel dizzy when I suddenly turned my head, or so it's going to be sudden movement, sudden positional movements. It could be secondary to trauma, or vestibular neuronitis as well. Symptoms, so it'll be positional, patient rolling over, looking up, looking back, getting out of bed, bending over. The other key, so remember we talked about duration is gonna key us in. It's gonna be how long these episodes last. How long does the dizziness or the vertigo last? And for BPPV specifically, usually it's between 10 seconds and less than a minute, right? So if it's more than a couple minutes, it's not BPPV. Just know it may take like 10 to 15 seconds for the nystagmus to elicit, but not the nystagmus, excuse me, the vertigo or the sensation of dizziness to elicit, but know that if it only lasts for less than a minute or a couple minutes, it's gonna be BPPV. All right, so our physical exam, we can do our Renee test. It's gonna be AC versus BC, that's normal. It can be indicative of sensory neural hearing loss, but these patients typically don't have sensory neural hearing loss. Weber would be midline, so when we do our Weber test, they will hear the sound equally in each ear. And then we'll have that positive Dix-Hall-Pike maneuver that we talked about. They can have horizontal or vertical nystagmus, which can be interpreted as rotary nystagmus, but don't worry about like getting into that. Typically, if it's peripheral, it's going to be horizontal nystagmus. If it's central, it's going to be vertical nystagmus. And keying on, it's fatigable. So after a few seconds of looking deeply into the patient's eyes, it will go away. Treatment, so first line treatment is going to be that Epley's maneuver. We'll talk about this in lab as well, how to position the patient and rotate the patient's head so that we reposition that otoconus back into its normal position. So that's the purpose of that maneuver. In clinic, I'll say, it is effective, but even if you decrease the patient's symptoms, they still want something to take home. So with that being said, we can prescribe some like vestibular suppressants to help with that nausea, right? Because remember, these patients have that dizziness or vertigo, and it may make them feel nauseated. So you can just say like, hey, I performed the Epley's maneuver. Maybe they're not satisfied with that. Okay, let me just give you a couple of days of meclizine to help with if the symptoms come back, right? But the first line treatment is going to be the Epley's maneuver. If it is recurrent, it might not be BPPV, and we need to refer out to ENT to see if it is BPPV or a differential within our peripheral vertigo differential. Now going into Meniere syndrome, also known as endolymphatic hydrops. So this, the pathophysiology is not well understood, but what's believed to happen is the endolymph, so remember it's fluid filled, it's starting to become distended, right? So that size is increasing secondary to whether it's allergies or some type of immunological response. So that endolymph has more fluid in there than what it should be. The episodic vertigo attacks, so they last between 20 minutes and a couple hours. So that's our distinguisher here, as opposed to in BPPV, it's going to last usually less than a minute. They will have sensory neural hearing loss. So that's another distinguisher that we can identify in our vignette. So the episodes are between 20 minutes and several hours, along with hearing loss. That hearing loss usually comes with the episodes, because during the episodes, the endolymph is distended and pressing against that nerve. So that's where that hearing loss is coming from. They may have tinnitus, they may have unilateral oral pressure, but those are the key indicators: the timing, and then that fluctuating sensory neural hearing loss. About 50% of patients have associated allergies, so you might see that in the patient's past medical history in the vignette. They may have hypertension. Again, that kind of makes sense because patients with hypertension, they have, their blood vessels are distended, they have high sodium intake potentially, okay? A physical exam, so for caloric testing, it may be impaired on the affected side, but it's not going to be super obvious. So those eyes will move to that cold stimulus, but it'll just be at a delayed response. Weber will lateralize to the unaffected ear, and then AC will be greater than BC, because if they do have that sensory neural hearing loss, that's what we anticipated on our Renee test. Labs, no specific labs for this medical diagnosis, but we're gonna still stay in alignment with our imaging and referral. So this typically presents unilaterally. If the patient presents to you with unilateral hearing loss, we're gonna get an MRI, refer to audiology to confirm their hearing loss. And then once the MRI comes back, it may show hydrope, so extension of the, or distension of the cochlea. But aside from that, if that's the only thing, they don't find any mass, we can manage this in-house and clinic. Our primary treatment for this patient would be dietary changes, so having them do a dietary log. Do they eat a lot of lunch meat? Do they eat a lot of microwave dinners, that kind of stuff, avoiding caffeine? We can prescribe them a diuretic to help with relieving some of that extra fluid. So remember, primary is dietary changes, and then secondary will be pharmaceutical. We'll prescribe a diuretic. Symptomatic treatment. So just thinking about when the episodes happen. So remember, they last about 20 minutes to an hour. They may have some hearing loss associated with those episodes. So we don't need to keep them on an antiemetic or prescribe them Zofran daily if they're only having symptoms associated with the vertigo attack. So you can prescribe them a medication, but just understand, like, it'll just be like for 3 to 5 days or until their symptoms resolve, and educating them that only take it when you're having an episodic attack. All right, check on learning. Can I get a volunteer?
A 65-year-old female presents with spinning dizziness for 2 days. She states the symptoms started when she rolled over in bed. She now has dizziness when she turns her head that lasts for about 30 seconds. A Dix-Hall-Pike maneuver is positive. Which of the following is the most likely diagnosis?
What are we thinking? Delta. Why are we not thinking A? Yes, very good, short duration. Also, no hearing loss for this patient, right? So reading through no hearing loss, duration, positional. I think you said that as well, right? And positional. So just kind of keying in on some of those factors in the vignette. All right, and then vestibular neuromyelitis, we'll talk about that. Because again, the patient is only gonna affect the vestibular portion of the nerve. So they're not gonna have the hearing loss, and we'll get into that as well. So it's no hearing loss, so that wouldn't align. Meniere's disease, we talked about that. It's usually 20 minutes to an hour, so it doesn't align with the episodes. And then BPPV, that's our 2 points, and this is not a perilymphatic fistula patient. It doesn't, no history of trauma, no hearing loss, that kind of thing. And we'll talk about that as well. All right, another volunteer, please.
65-year-old female presents with occasional dizziness for 2 days. She states the symptoms started when she rolled over in bed and it felt like she was spinning. She now has dizziness when she turns her head that lasts for about 30 seconds. A Dix-Hall-Pike maneuver is positive. Which of the following is the most appropriate management for this patient?
What is this patient's diagnosis? Yes. And so what is our answer? A, ectodermal maneuver. We can prescribe meclizine, but that is not the most appropriate. That's not our primary treatment. We don't need to refer them out to ENT. That's otorhinolaryngology. So ENT, we always say HEENT, ENT, HEENT, but otorhinolaryngology, otolaryngology, those are all the same. Like, do we want to say otorhinolaryngology all the time? No. Somebody say yeah. Benzodiazepine is not appropriate, and then the cold caloric testing, there's no purpose to do that at this point. All right, let's take a quick break. Let's take 10 minutes and then we'll finish this and go into our next lecture, because I think it's only like 32 slides, so it's pretty short. So let's get started. We'll be back at 46, page 46.
Guess that'll work. I don't. There might be a faster. Yeah, I literally just have to write it. Then I can copy paste it, and then every time I copy my files from the source. You know what I mean? Like I use that because I copy and slide and compose it. I have them all sent through. Like this would take pictures. I have all of them. So I copy the first one, the second thing, the first one I close it, and go through and then save that first one as a name. You know what I mean? Like, yeah.
So that way you're not like,
Yeah.
It's like my wife changed like our not the sheets but the comforter a while back. She changed it from like a comforter. No, like she went. Yeah, so we found like a decent price like just insert at TF Action that she found a comforter she liked. But like we started getting it every month. It's so cool. And I had a fan. That I used in case like guests need like extra. So I didn't have an extra. I had a plug.
So I have a due date and a due answer. Like on the top of it, and then I have just the date of the due date. Get it good.
It's funny.
It's
But the thing is like when I go to sleep, I don't feel hot. I'll wake up like at 2 or 3 in the morning and like I'll literally be soaked with sweat and like get out of bed and like grab my phone from the couch and take my phone. But then get out. I like my shit to be cold.
It was a little.
It's cool. I need to be cool all day. Just shut my AC.
They sound like in mid-90s or something.
That peaks really good when I'm on hard.
You should bake in the fall.
Is it? Monday to Thursday. My wife is right there. So we're like, my house is already off ball. That wasn't very
I told her she could decorate my place and take it all down. That's the worst part. Is like kind of was easy taking it all down.
She loves it. She like especially the turnover from fall to Christmas. She fucking loves it. She loves taking the balls up.
My mom loves Halloween. Then she does harvest, which I think that's a thing.
It's like it's a mix because it's like fall. You have fall like September, so you never fall. You have fall in the middle, and then you go back to fall. My wife does all fall, and then she adds in like all the stuff, and then she takes it away and go back to fall. Because it's the same shit. Like because we got fall next year. It's like it's
Alright, back to the interview, let's get started. I have 8:46. Alright, any questions on what we went over so far, as of right now? No questions, alright. So continuing on, we're still in causes of peripheral vertigo. So labyrinthitis is inflammation of the vestibulocochlear nerve and in the labyrinth. Causes, it can be idiopathic but usually it's viral or bacterial. symptoms, so commonly unilateral. Remember, it'll be sensory neural hearing loss because we're in the inner ear. And our differentiator is that continuous severe vertigo, as opposed to the episodes with Meniere's disease where it's like 20 minutes to an hour, or if it's BPPV where it's about 30 seconds to a minute. They may have some tinnitus plus or minus a fever depending on the cause, because it can, a bacterial infection or a viral infection can cause this. And on physical exam, they may have that horizontal nystagmus. For treatment, so we can do a couple things. We can provide them the vestibular suppressants if they are having that continuous sensation of feeling as if they're off balance, because they may develop nausea and vomiting. And if they have a bacterial infection, and of course we treat that with antibiotics. Also know just how, again, how close in relationship the middle ear is to the inner ear, so this can be caused from AOM, so acute otitis media. This could sequela into a labyrinthitis. If again, same guidelines, if the patient has unilateral hearing loss, we're gonna get the MRI and then refer them to audiology. And if the patient is refractory to the treatment that we provide, then we can refer them to ENT, or if we see any abnormalities on the MRI, refer them to ENT. Now, vestibular neuritis, previously known as vestibular neuritis, inflammation of only the vestibular portion of the vestibular cochlear nerve, which is cranial nerve 8. This is the third most common cause of peripheral vertigo, not really significant, but the causes can be idiopathic and then more associated with patients that have a HSV-1 infection. So you might see something like that in the past medical history for a patient presenting like this. Symptoms: vertigo, sudden, continuous, so very similar to labyrinthitis. Worse within the first 24 to 48 hours. They may have plus or minus that vomiting. But key thing here is no hearing loss, because it's only the vestibular portion of the nerve that is being affected. No change on our HEENT exam. We're still going to do a full HEENT exam. We would not suspect any hearing loss, so that's a key indicator for us. We can do that Romberg or that Fukuda test. Those aren't specific. Those are just tests that we can do to assess for our differential diagnosis, and then we'll note that fatigable horizontal nystagmus. Treatment, it'll just be supportive care, giving them the meclizine or the diazepam short course, and then if it's persistent or if they come back and say like, hey, I've tried the meclizine and it's just not working, it's actually getting worse. It could be a central cause, or if they develop worsened symptoms like neurological symptoms, it may be a mixed vertigo cause. So that's where we will refer them to ENT. And then going into traumatic vertigo, we talked about this a little bit already, but so essentially it's vertigo from some type of trauma from the head or neck. It can be caused by labyrinthine concussion. That's the most common cause. That basilar skull fracture, cupulolithiasis. So that's where that oticona, it actually dislodges and attaches to the cochlea, and a perilymphatic fistula, which we'll talk about. All right, symptoms. So of course vertigo, because this is traumatic vertigo. Following a head injury, so that might be the inciting event. May last days to several months, but again, it could be for this continuous or episodic, so that's not really helping us determine. What's going to help us determine is the past medical history or the inciting event. Plus or minus hearing loss if they have a basilar skull fracture, right? So you might see some signs of that on physical exam. No change on our physical exam. We're still going to do the same test to assess for this patient's vertigo. And then just kind of highlighting again on those indicators for a basilar skull fracture. So that retroauricular ecchymosis, the ecchymosis underneath the eyes, or cerebrospinal fluid coming from the nose or the ears. treatment for these patients depends on the severity, so if they're coming in after a really bad automotive accident, right, we're gonna give them supportive care, IV therapy, if they need antibiotics, that kind of thing, so it's just really gonna depend on, their presenting symptoms. And then, this is where we get, if we have signs of a bastard skull fracture, we wanna get neurosurgery involved, not neurology, neurosurgery. If the patient doesn't have signs and symptoms of a bastard skull fracture, that's when we can get ENT involved because they have this traumatic vertigo, but we're not really sure what's going on. Is it central? Is it mixed? Is it peripheral? We know it's traumatic, but we're not really sure what's the cause of it. All right, again, what are some signs of a bastard skull fracture? Halo sign. All right, and then going into our last differential cause of peripheral vertigo, so that perilymphatic fistula. So this is where fluid leaks from the inner ear into the middle ear. So that round and oval window becomes, the bones protrude into those windows, and that's where that leakage comes from. It could be secondary to a physical cause, head trauma, aerotrauma, diving, flying, even weightlifting. I mean, some people enjoy like competitive weightlifting, but that can also cause it because when they're squatting, that pressure buildup of them holding their breath could also cause something like this. So I don't think it has to be like an automotor or a car accident or anything. Plus or minus vertigo, sensory neural hearing loss. Physical exam, so we'll do our full HEENT exam. We want to make sure we do our cranial nerve exam. We expect AC over BC. Weber will lateralize to the opposite ear that's affected if they have that hearing loss, plus or minus a perforated TM. And we definitely want to get ENT involved if we are thinking of perilymphatic fistula. And then lastly, the vestibular schwannoma or acoustic neuroma. So this is where cells, those Schwann cells develop on the nerve and develop a schwannoma. Overgrowth of the Schwann cells, it could be secondary to hereditary neurofibromatosis, which we'll learn about in neurology next semester. They may have unilateral sensory neural hearing loss or continuous vertigo, or they can present together. But remember, if they have that unilateral sensory neural hearing loss, we want to get an MRI to further assess, and we might see a vestibular schwannoma on the MRI. Physical exam, so no change. We'll still do the full HEENT exam, do our cranial nerve exam. Sound will lateralize to the opposite ear that's affected if they have hearing loss, AC greater than BC, and then getting that MRI to assess for this condition. And then treatment is really just gonna depend on the size and the progression of it. So these can turn into malignant schwannoma. It's very rare, but that's why I put chemotherapy there. So it's gonna be up to ENT to decide, do they wanna remove it? Has it progressed to malignant vestibular schwannoma, etc. All right, just highlighting again on that referral process, referring to get the MRI, audiology simultaneously, and then if the MRI is abnormal, then we refer to ENT. Any questions on what we covered so far? Let's switch to. All right, finished up, external ear, middle ear, inner ear. Now we are going to discuss diseases of the nose and the paranasal sinus. This is our course terminal objective. You can take a look and read over that. And then our enabling learning objectives. So just some basic anatomy, understanding what the sinuses are, their open filled cavities. We have 4 of them, the sphenoid, frontal, ethmoid, maxillary sinus. These are the functions of the sinuses. I won't I know you guys are familiar, but it's just a refresher of the purpose of them and understanding that they're air filled, and this gives an opportunity for bacteria to harbor in there and for them to develop an infection. So if bacteria harbors and fluid develops in there, that's where we have infection festering within those sinuses. And that comes into play with the mucus secretion. So those goblet cells, they secrete the mucus, and then the olfaction, so that for our ability to actually smell. So it does have a part of that as well. Now, our first diagnosis is going to be acute viral rhinosinusitis. So these are some of the most common symptoms. So when I go over this, just think about when people say common cold, acute rhinosinusitis, or if they're like, I got the bug, like all of that is the same thing. So just so you kind of understand, like common cold, acute viral rhinosinusitis, all of that is one and the same. Or upper respiratory infection, like those are all the same. Sneezing, they have sneezing malaise, so that's that fatigue, headache, cough. Usually it lasts less than 10 days. We can develop a short or like a 4-week or acute viral. So don't get too caught up in that, but somebody can have viral rhinosinusitis for longer than 10 days, but ideally it presents for less than 10 days. That's kind of an indicator for us. All right, these are some causes. So adenovirus, rhinovirus, and then there's numerous subtypes. For our physical exam with the patient, we may see some erythema, some edema in the nasal passage. We also may see watery discharge, so it can be discolored, right? Because if a patient is sneezing, coughing, if they have some irritation, they might irritate their nasal canal and they may have blood. So, but it can be discolored, but usually the consistency is like watery. Supportive treatment for these patients, no antibiotics, at least within the first 10 days. Like at least allow the patient to try, give them analgesics, maybe some cough drops, something like that. Just don't outright prescribe them antibiotics. We could also do nasal decongestants or oral decongestion, so that's pseudoephedrine. If we prescribe them the oxymetazoline, so remember we talked about the rebound medicamentosa or rhinitis medicamentosa. That's where essentially that oxymetazoline reverse effects and it worsens the patient's symptoms, because ideally it would vasoconstrict the vessels, but instead it rebounds and it actually dilates and causes more congestion in their upper airway. And we can prescribe them the hypertonic saline nasal rinses. Those are actually pretty effective. So I've seen patients use those as well. Complications, so eustachian tube dysfunction, they might have some transient middle ear effusion, and it can sequela into a bacterial sinusitis. This is extremely rare, but just kind of thinking about the pathophysiology, which we'll get into, it can happen, but generally it's not. Generally, this does not happen. All right, can I get a volunteer for this question?
29-year-old, previously healthy male, presented to the TMC with 12 days of stuffy nose and right-sided sinus pressure. He was treated symptomatically and released. What is the most likely diagnosis?
What are we thinking? Anybody? A. What's wrong with this question? Anybody? Yep. Yeah, I could definitely give you some more insight on the patient signs and symptoms. And then just so I don't confuse you all, so it says 12 days here. In like for testing, it'll be less than 10 days. So you have a clear guideline on viral is less than 10, bacterial is going to be more than 10. But just know, like in clinic, they could be present to you with 14 days and still have a viral rhinosinusitis. So just know that. Okay. All right, I'm gonna click through this and then we'll kind of go through it.
In your experience with the pants, is there usually a pretty clear delineation?
Absolutely, yeah. And it'll be obvious, kind of like what your classmate was saying, like a purulent discharge, watery discharge. Do they have a fever? How long has it been going on? Yeah, more details. Facial pain, that kind of stuff. All right, so just kind of going through the pathogenesis of acute bacterial rhinosinusitis. So we've transitioned this bacterial rhinosinusitis or bacterial infection of the sinuses. So bacterial colonizes. Am I saying that right? Bacteria colonizes, thank you, and or a viral rhinosinusitis can sequela into bacterial rhinosinusitis. The swollen mucosa exacerbates that. The osteomeatal complex obstructs, and then the mucus builds up. If it's less than 4 weeks and this patient has these symptoms, it's going to be acute versus subacute and chronic. Subacute is 4 to 12 weeks, chronic is greater than 12 weeks. It is important to know the most common organisms. So for this one, it'll be Streptococcus pneumoniae. Alright, these are some different causes or different types of rhinosinusitis or maxillary. So that's the most common. Acute ethmoiditis, sphenoid sinusitis, acute frontal sinusitis, or it can be a hospital-associated sinusitis if the patient was recently hospitalized. So these patients will present with purulent nasal discharge, maybe some obstruction, congestion, that facial pain, pressure. So that's also equivalent to sinus pressure. So if you see that, that's the same thing as facial pressure, sinus pressure. Fever, so remember greater than 100.4 in degrees Fahrenheit or 38 degrees Celsius. Anosmia. So that's where they cannot smell. And then perception of foul odor or dental pain. So if they get to a point where they're having some dental pain, they may have some other things going on, and we'll talk about that in our next lectures. The keys here is the facial pressure, the fever, and the purulent discharge. Purulent is going to be like thick, muky, like a mucus, like yellow, maybe green. They might have some blood in there, but the consistency is generally pretty thick, kind of like the baby. All right, going into imaging. So radiographs are generally not indicated, in CT only in certain circumstances. Hospital acquired, if they have comorbidities, if they're refractory to treatment, those are some reasons for a CT. For these patients, our primary treatment will be symptomatic treatment, so NSAIDs or oral nasal decongestants, plus or minus steroids, plus or minus the nasal saline. So it's just going to depend on your practice as to what you select to treat these patients. Reasons for us to prescribe antibiotics are the following. So if the patient presents to you and they're immunocompromised, so they have HIV, they have AIDS, maybe they are diabetic, they have comorbidities. If the patient has severe symptoms, that facial pain, they might describe it as that sinus pain, facial edema, fever. If they've attempted symptomatic treatment, so you prescribe oral decongestants and you prescribe analgesics and they come back and it's not effective, that is an indicator for you to go ahead and prescribe them antibiotics. So you try symptomatic treatment, but it's not helping. And then if you prescribe them the symptomatic treatment and it worsens, that's another reason too. If it worsens after a couple days, they come in, you give them analgesics and oral decongestants, it gets a little better, and then it worsens, that's another reason to prescribe them antibiotics. All right, and so these are our treatment of choices if we're going to prescribe the patient antibiotics. Augmentin Doses, don't worry too much about the doses. In clinical practice, you'll be able to reference whether it's up to date or open evidence, so that's not really pertinent. It's understanding what organism is causing this condition, and then what medication do you need to treat them with. Typically, if it's a healthy adult less than 65, we're gonna use regular dose, and then, but if they have comorbidities or over 65, then we'll go to high dose augmentin. Consideration, so if the patient does have a penicillin allergy, we can use doxycycline to treat these patients. At this time, it's not recommended to use the macrolides or Septra and second and third generation cephalosporins just because they're not as effective. We can refer to ENT if necessary, but this is something that we can handle in-house probably like 95% of the time. And when I say in-house, I mean in clinic. If the patients persist beyond 4 weeks, just consider your diagnosis, so subacute sinusitis or chronic, and you may need to switch your antibiotic. If you've prescribed the antibiotic, the patient is medication compliant, and it doesn't treat it, we may need to switch the antibiotic or refer to ENT because it could be something else going on. All right, if I could get a volunteer for this question.
21-year-old male presents your clinic with sinus congestion, left-sided facial tenderness, and a cough for 2 weeks. He states symptoms have not improved despite over-the-counter decongestants. His vital signs are blood pressure 124/72, temperature is 101.5 Fahrenheit, respirations of 12. Physical exam is remarkable for left frontal sinus tenderness and purulent nasal discharge. He has no history of allergies to medications. Which of the following is the most appropriate treatment?
Our patient presents, they have left-sided facial tenderness, that cough for 2 weeks, so we're at 14 days for this patient. They tried decongestants, but it didn't work. Vital signs, like a low-grade fever, 101.5. And then on physical exam, frontal sinus tenderness, so that screams that bacterial rhinosinusitis, and we're going to prescribe augmentin. So complications of a bacterial sinusitis infection are subacute chronic, which we talked about a little bit, orbital cellulitis and abscess, osteomyelitis, and then that cavernous sinus thrombose and the intracranial extension, that's like if it's just untreated for weeks or months. Like those are pretty rare and extensive. Or if a patient is hospitalized, those are reasons or ways that a patient can develop those complications. For orbital cellulitis, so this is infection of the skin, fat, and muscles around the orbit of the eye. Higher risk patients that have that ethmoid sinusitis, because it's right here in the middle of those ethmoids. Physical exam, patient may present with blurriness, spottiness, double vision, sensitivity to light even, or they may have a bulging, swollen eye, that erythematous eye, kind of like in this picture here. Orbital pain, so when you do your physical exam, it may be difficult for them to even complete that when you're testing for nerves 3, 4, and 6. And then for treatment, so this is a collective treatment. We have to start IV antibiotics, CT, and then we're going to refer to ENT or ophthalmology depending on our setting. So in that instance, we would likely be in ER. Right, but we want to kind of get the ball rolling for our specialists. And then if they do present to you if you're at a battalion aid station or at a TMC at like a local clinic, let's coordinate care to get them over to the ER. Don't just send them over there. I usually call and say, hey, I have this patient coming over, just so it's a smooth transition. An orbital abscess, so this is a sequela from orbital cellulitis. So this is where the paprecia, so it's infected, it's a bone within that orbit, and a pocket. When I think about an abscess, I just think about a pocket-filled pus, like a pocket filled with pus or fluid, like infected fluid. Like think about it like that. So anytime an abscess happens, or you think about an abscess, like it goes from cellulitis into an abscess. That infection is harboring in a pocket and is filled with fluid. For the physical exam, so they may have that proptosis, so bulging of the eye, ophthalmoplegia, so they cannot move their eyes when you're doing your cranial nerve exam, or pain with movement of their eyes, and the treatment is going to be the same for these patients as well. We won't know really if it's orbital cellulitis or an orbital abscess until we get imaging. All right, another volunteer.
A 22-year-old female presents to the clinic with 2 weeks of sinus pressure, nasal congestion and headache. She attempted over-the-counter ibuprofen and pseudoephedrine without no significant past medical history. What is her most likely diagnosis?
What are we thinking? Anybody? Are you guys still awake? B. Okay. Do we have a poll? All right, B, we are thinking B, so 2 weeks of sinus pressure, that nasal congestion. She attempted the ibuprofen, pseudoephedrine, so that's symptomatic treatment. The only thing I want to highlight here, just so you don't get too tuned in on the slide, so understand that you don't have to have all of the symptoms on a slide for it to be bacterial sinusitis, right? It's going to be like the most common, like the fever, the purulent discharge, or the facial pressure, or they may have like a temperature, a purulent discharge, but it doesn't have to be all of the symptoms to be bacterial. You got to kind of like clinically put that together, that it's bacterial sinusitis. Now going into invasive fungal sinusitis, this is extremely rare. Those are the most common causes of this condition. It presents similarly to a bacterial infection. Biggest difference is they may have extreme or severe pain, maybe some visual symptoms as well, but that can also be associated with bacterial. Past medical history, so make sure you're taking a look at that because they may have some immunosuppression, diabetes, renal failure, HIV or AIDS patient. These are things that put them at a higher risk for a fungal sinusitis. On physical exam, seeing that clear or straw-colored discharge along with that black eschar, so that's necrotic tissue. So that'll kind of be your indicator to tune you in on this may be fungal or as opposed to bacterial. Treatment, so this is a medical emergency and it requires surgery. We're gonna start voriconazole, order a CT, and then get ENT and ophthalmology potentially involved. Again, if we are in a clinic setting, we wanna refer them to the ER or ENT ophthalmology because it's not gonna be anything that we can do for this patient. These are just some alternative antifungals that we would start. You start the voriconazole because that's going to be broad spectrum coverage, and then once we do the culture, we can kind of tailor our antifungal treatment. Prognosis is about 57% overall as long as it's caught and we treat it and we get the proper care for this patient. But just take a look at that 100% mortality for patients that have AIDS, leukemia, or lymphoma. This is a picture of that black eschar on the left, doing a physical exam, and then the progression of that on the right. So it progresses pretty rapidly. And then this is a patient who had a fungal sinusitis, and then prior to surgery and then after. So it doesn't look like it's invading as much on that first picture, but then it's just so rapid that, yeah, they had to remove a lot of bone. All right, one more.
25-year-old male presents to the ER with sinus pain and nasal discharge for 4 weeks. Patient states he was prescribed augmentin 10 days ago for symptoms, but there's been no improvement. Past medical history includes seasonal allergies and HIV. Today, his facial pain and headache are worse. On physical exam, he has nasal edema, nasal discharge, and a black eschar on the middle turbinate. Which of the following is the most appropriate intravenous medication to start this patient on?
Echo. Any questions on that, Vinny? All right, any questions? All right, I'll stand up here just to wait around to see if you guys have any questions. And I think, when is our next, our final lecture? Tomorrow afternoon, okay.